Okay, so this lecture is about hemolytic disease of the fetus and newborn, or HDFN. And we, of course, are worried about acute hemolytic transfusion reactions in the blood bank, but we're also part of the diagnosis and workup of hemolytic disease of the newborn, so we need to know how that works. Hemolytic disease of the newborn causes, or the old-fashioned word of it, term for it was erythroblastosis fetalis. It's caused, as we know, by maternal IgG, which is directed against some fetal antigen. We know that it has to be IgG because the other species of immunoglobulin don't cross the placenta. So it's the IgG species that causes the problem. And the reaction that you can have can be anywhere from relatively mild to severe. And that is all based on how strong the reaction is between the antibody and the antigen. In some cases, the fetal cells might just be sensitized, covered with antibody, which would still reduce their overall lifespan. But in that's relatively mild case of HDFN, or it could be incredibly serious where full-on lysis takes place, and all of the same issues that would occur when those red cells dump into the plasma. Now this can be, HDFN can be diagnosed either prenatally, before birth, antenatally around birth, or antepartum after the baby is born. And those, the blood bank has a role in any of those diagnoses. What happens in the case of HDFN is the mother becomes sensitized to those fetal antigens when there is some sort of hemorrhage, fetal-maternal hemorrhage, between the mother and the baby across the placenta. That can occur, as we said, it can occur either during the pregnancy, which would usually be associated with some kind of fall or some kind of trauma, or it can occur, which would put that pregnancy at a risk, as well as future pregnancies. Or it can occur potentially during labor or delivery, where there might be a slight mixing of blood between the mother and the fetus. Now, if it occurs during labor and delivery, remember, immune responses take time to develop. So in that particular case, usually that first pregnancy, or the pregnancy in which the sensitization occurs, would not be at risk, but future pregnancies would be at risk. So what happens then, once the mother is sensitized, the IgG, either during that pregnancy or in future pregnancies, crosses the placenta, and it's going to attach to the fetal red cells, where, again, worst case scenario, it can cause lysis. If lysis is generated, then you're going to have fetal anemia. And that anemia is then going to trigger in the fetus erythropoiesis, right? Which is a normal response to low red counts. And that means immature red cells are going to be pushed into the peripheral circulation from the bone marrow. The worst case scenario of this lytic event is that you end up with edema from the buildup of these toxins. Edema can occur in particular in the peritoneal and the pleural cavities, most dangerous. And when that occurs, when that particular symptom occurs, that symptom is called hydrops fetalis. You can also end up with another very severe symptom, and that's called hemorrhagic pneumonia. And these are the babies which are most severely affected, where there has been a decrease in the coagulation factors, in particular fibrinogen, and DIC is actually present in the infant. what happens during the normal immune response, your coagulation factors are going to be depleted, in particular the vitamin K dependent coagulation factors. Fibrinolysis is going to be triggered because of all the coagulation, and then the infant starts to ooze and bleed because of all of these tiny little clots that have occurred. Your hemoglobin and the hemoglobin byproducts, which had been dumped into the plasma, those are insoluble, and when they're in high concentration, they're going to end up accumulating in the renal tubules. Remember, the kidney function isn't exactly the same in the fetus as it is in the actual born person. So you're going to get this damage to the kidney. You're going to get this accumulation of fluids in the lungs and in the peritoneal cavity, and so you end up with a severely in danger fetus. If the child still ends up being delivered, not necessarily having the most serious case, but having any kind of fetal hemolytic disease of the fetus and newborn, if the child ends up being delivered, remember that when a normal child without an immune problem is delivered, you're going to have a bilirubin issue. When you add on top of if you remember correctly, babies don't have complete liver function, right? That's normal. Even a healthy newborn, the liver isn't quite kicked in yet. And one of the biggest things that's deficient is gluconyltransferase, which is used, of course, in the processing of bilirubin. So now if you add to that normal misfunction the fact that a child who has HDFN has this whole dump of indirect bilirubin from the lysis of the red cells into the plasma, and the liver can't process it, that bilirubin is going to end up becoming bound to albumin. It's going to become deposited in tissues, and it's going to increase in the tissues. The baby could be born completely jaundiced. The problem with bilirubin is that if it becomes deposited in tissues like in the central nervous system, it can cause some serious damage there. In particular, it can cause deafness, it can cause mental delay, and of course it can even cause death. This is just an outline. This is not anything you have to memorize, but this is just an outline. I want you to look at this at some point and take a look at exactly what the cause and effect is for what's going on inside that infant. Okay, you have the boxes are basically the results of that red cell lysis, right? You have loss of oxygen carrying capacity. You have erythroblastosis and reticulocytosis, which would be normal functions of anemia. Then, because of the toxins and the immune deposits, you've got an enlarged liver and spleen. A liver, by the way, which is not functioning anyway to normal levels. And then you've got because again of those immune deposits, your fetal and placental circulation is also going to be compromised. So take a look at this and look at all of the real mess that occurs when you have HDFN. Now remember, at birth, it is normal for a baby to develop some bilirubin issues. The bilirubin of a newborn is expected to be higher, and the major reason is they have little baby livers, and their livers aren't able to process the red cells. They had been the liver function really had been processed or managed before birth by the maternal liver. So once the healthy infant loses the placenta and their own liver function isn't really up to snuff, you're going to see increasing bilirubin. But with an infant who has an increased production of bilirubin because they have red cell lysis, you can see that the real problem is that their liver may not catch up, okay, in time to really alter the effects of all that bilirubin in the skin. And if you look at the infant on the left where it says before phototherapy, you can see all the bilirubin deposits, the same kid, all the bilirubin deposited in their skin. They're gold. That's when you go through the nursery, you know exactly who has HDFN. They're gold, okay? And then the infant after phototherapy, because we use UV therapy to break down that bilirubin in the skin and hopefully help the infant to process it quicker by using sunlight to break it down. Now, as we know, not all antigens are created equally, and part of that is not all antigens are developed at birth, right? Not all red cell antigens are fully developed at birth. So we know that not all blood group antigens can cause HDN, and you have to know which ones can cause it, and more importantly, which ones don't. So if you look down the list there, which ones are no? Not no to moderate, but no. And when we're talking about blood group antigens, Lewis, P1, and Big I, those ones are not well developed at birth, so they usually don't cause HDN. Okay, those are the ones that really we don't even think of causing HDN. Also, you have to remember that the antibody produced against the antigen has to be of the IgG class because it has to be able to cross the placenta. So knowing which class of antibody is produced against that antigen, we know what the risk is for HDFN. Okay, so for example, we know that the class of antibody produced against the ABO blood types is IgM. So if all the mother has is IgM antibodies against A and B, then no, it's not going to cause a HDHN. But you can see that on the chart it says no to moderate, and that's because you can become sensitized against an alternate blood type. If you do become sensitized against an alternate blood type, you will develop an IgG. So there are a certain percentage of persons who do become sensitized, and it can happen during fetal maternal bleed. It is possible. And in that case, if the mother develops an IgG against that blood type, then you can get moderate HDFN. Whereas if we look at the antibodies produced against, pardon me, against Lewis, against the M and N antigens, against P1, those are IgM. So IgM antibodies are not going to cross the placenta. They're not going to be a problem. So that's why we can say no. We don't see HDFN in those cases. And the reactions, by the way, in this, the type of reaction that you're talking about really is HDFN. But there is this, of course, list, the exceptions to the rule. Now, lab investigation to determine the risk of HDFN really starts before the kid is ever born. We really start with the maternal history. Okay, does the mother produce any IgG against some high-risk antigen? Now, of course, the most significant antigen and the most common is going to be D. So we need to know if the mother produces an anti-D. Well, her risk of producing an anti-D is related to her D status. If she's D negative, that's the most likely case where she's going to produce an anti-D. So we have to be aware of those mothers, and that testing has to be done quickly. So now, remember that the population as a whole, there's a 75% chance that you're D positive. So once we know that the mom is D negative, we know that there's a 3 out of 4 chance that the dad is D positive, in which case even if the least possible chance for our infant is a 50-50 shot that the child is going to be D positive. If the child is D negative, there's not going to be a problem. But remember, that's only 50-50. And the other thing to think of when we're talking about D and the maternal history, you do have to do weak D testing, because the weak D mother is potentially at risk of developing an anti-D. We know that can sometimes happen. So you need to do weak D testing to make sure that you can really predict all the women who are at risk for this situation. And to do that, we just do the indirect Coombs. We do an IAT test, which is essentially, it's an antibody screen. That's basically what you're doing. And it has to be done, though, with IgG antiglobulin. And it has to be done with untreated red blood cells. Okay, you're not going to use the polyspecific antiglobulin because remember, you're looking specifically for antibody. You're not looking for complement, you're looking for antibody. And if you use any kind of enzyme-treated red cells, that'll allow the detection, that'll reduce the number of antibodies that you'll detect. So you want to make sure that you leave all of the antigens intact and that you don't change them in any way when you're looking specifically for a risk factor here. Now, if your mom is D negative, you'll do that prenatally. Usually, women come in the first month that they know they're pregnant. So we'll do it then. But then we'll also do the test again later on during pregnancy. But if the mom is negative, if she proves to be negative, and that's because we want to be sure that nothing has developed. So you'll repeat that test at 28 to 30 weeks of gestation for the D negative moms. In an otherwise uneventful pregnancy, you would repeat it just to be sure that she hasn't become sensitized in any way. Now, if you end up with a positive IAT where you found that there is some kind of antibody that the mother has, because you've done, an IAT is basically an antibody screen, okay? So then you have to actually classify, well, what kind of antibody does this mom produce? And remember, you're going to determine, is it an IgG or is it an IgM? For the most part, we can do that by the temperature at which it responds. Okay, so cold is IgM, warm or 37 or AHD is IgG. Okay, that's easy. Remember, if it's one of the ones we're not worried about, if it's a Lewis, if it's an anti-P1, those ones, we don't worry about those. They don't cross the placenta. We're not going to worry too much about them. If it's an IgM, we're not going to worry too much about it. It doesn't cross the placenta. Okay. However, if it's a D, we need to know that because this patient is going to be a candidate for RHIG treatment. Now you're going to do, once you get, the first visit, the mother gets the antibody screen done, and if it was positive, you would do a titer. That's your baseline titer. That should be completed within the first trimester if it's a previously sensitized mom. So you have two, you have the D negative moms, they're not sensitized is what you're hoping for. So in those ones, you're just going to keep doing antibody screens to make sure that they stay unsensitized. For the mom who has been sensitized before, you need to do a baseline titer. And that baseline titer is going to be your standard against which you compare all the future titers that you do for this mom. Okay, and you're going to repeat those titers 2 to 6 week intervals based on what the doctor determines the risk is. Okay, what that means is for the lab is we have to maintain that initial sample, that first baseline sample, because when we run all future titers, we want to run it in conjunction with that baseline sample, and that ensures that there's no variations just based on technical skill as far as creating the serial dilution. So if you end up with a mom who's sensitized, you have your baseline titer, you don't throw that specimen away, you put it in the freezer. Each time a new specimen comes, you take that baseline out and you run the new specimen concurrently with it. And that ensures that your titer results are accurately compared. Okay, so those are the things that were, oh, and the critical titer, where they're going to determine, in particular for anti-D, will be done, the titer sort of point break, the break off there, is if you get a titer of 1 to 16 or 1 to 32 at the AHG phase, that's usually considered significant enough for a doctor to take some kind of precautions against an anti-D. Okay, now other antigens are going to have different cutoffs based on the medical director that's there. Like, for example, anti-Kel, those titers, the critical titers, are generally lower. And that's because Kel, the antigen, is present even on early red blood cell precursors. So we would have to be worried about antibodies targeting the bone marrow in that kid. So the cutoff level would be much earlier. Now, those are the factors that are going to come into play when we're talking about screening and monitoring the mother. For the fetus, however, there's also monitoring that's going to be done. Okay, and the major type of screening that's going to be done for the fetus today is ultrasound monitoring. This is basically the standard now, mostly because of the reduced risk. Amniocentesis can still be done, and we'll talk about that in a minute, but with the low risk of ultrasound, that's really the method of choice these days. And we've talked about this before in other class. The methodology that they use is the color Doppler ultrasonography, which will measure the blood flow in the brain, and what's the speed of that flow. And if you have an increase in the blood flow velocity of a fetus, that's associated with anemia, which would be due to increased cardiac output, decreased blood viscosity. So those things would point to the fact that the child is having some difficulty. Okay, and that's again, they actually use the ultrasound to measure the peak systolic velocity in the cerebral artery of the fetus, which is again much safer to do than amniocentesis. Now, amniocentesis, if you are collecting a specimen, certainly you're going to look at the levels of, basically what you're looking for is bilirubin here. What's the bilirubin content of the amniotic fluid? Remember that the change in optical density that we're looking at is at the baseline of 450 nanometers for bilirubin. Okay, you did this in chemistry lab, I believe. So when you see that change in optical density, you're going to plot that on a graph according to your gestational age. And then that graph is going to be read in zones, which correlate with the severity of HDN. Okay, now that means you need to be accurate on your gestational age. Okay, and you then also can use the same specimen, the amniotic fluid, if you determine by the bilirubin that this pregnancy probably needs to come to an end. You can use that same specimen to determine a fetal lung maturity using a lecithin sphingomyelin ratio, which is a test to determine how mature the infant's lungs are. And if they're mature enough, then you can determine whether or not the child will have breathing difficulties after birth. Now, assuming that the child does have issues, basically you have a couple of possibilities for treatment. There is the possibility of intrauterine transfusion. If the pregnancy can go on longer, it is possible for you to transfuse some blood to alleviate the anemic symptoms that the child is going through. But really, if you get a serious buildup of bilirubin, you're going to have preterm labor. They're going to have to take the child early to make sure that the effects of the bilirubin can be mitigated. Now, these are just pictures of both the ultrasound monitoring that you would see, which I'm not a radiology tech. I have no idea what those mean, but they're very pretty, very colorful. But the Lilly graph there is one example of the how we plot those bilirubin levels out of an amnio fluid, okay? And you can see that the graph is broken down into 3 quadrants, which would correlate with the severity of the HDN, okay? So you can see the earlier on, the earlier you are, once you get your reading. So here's what we're going to do. So here's your 450 nanometers. You read it up and over, and you get your levels of bilirubin, right? Your concentrations of bilirubin. Then you take this information and you go to these graphs, and you're based on the week's gestation. Here's your concentration, but now your X line is your week's gestation, and you can see the 3 zones that you're in. 3 being the worst possible scenario, and the pregnancy probably has to end. And this is related to, again, same thing, both the Lilly graph and the Queenan graph just give you the basic ideas of what the danger is for the fetus, okay? What's the most likely case that they're having some kind of condition going on. So you don't need to use these graphs. These are plotted by the instruments for us, but you do need to know what they're used for, okay? The Lilly and the Queenan curves. Now that intrauterine transfusion, that occurs through what's called chordocentesis, where using ultrasound, they're able to access the umbilical vein, okay? Obviously, you don't do this, the physician does this. But there's pluses and minuses to this. The plus is that, of course, you can obtain a fetal blood sample, and that fetal blood sample can have tests done like a hemoglobin, a hematocrit. You can have a direct bili done at the level. You can also do some genotyping off of the fetus doing this technique once you get the specimen. And then you can even do, send the specimen down to the blood bank, and we can find out specifically the antigens that are present on the fetal cells that are causing the problem. Unfortunately, there is a risk. And of course, you can give a unit of however much blood this fetus might need to alleviate the anemia. But the drawbacks are that this is a high-risk procedure. It's invasive, and there is actually a fetal mortality rate reported with this between 1% and 2%. Okay, now remember, you wouldn't be doing this if this fetus is perfectly normal. So this fetus is at risk anyway. So does this exacerbate what is already their risk state? That's hard to describe. Okay, so now in most cases, we're going to do all our typing, and we're going to, we have our prenatal typing that's done on the mom. We do all that information before the baby's born. But for the most part, most of our typing on the baby, most of our work on the baby is done postpartum when they're born, okay? Now, that includes they could be born preterm. They're still born, so we can get access to their blood. The blood specimen that we're going to get is going to be a cord blood specimen that should be collected right away at birth. And there's an important thing to note about cord blood is during the labor and delivery, there's lots of things that are being used to help prevent infection and to help the process go faster. And one of them is Wharton's jelly. It's commonly used in the labor and delivery room, and it may get into the cord blood. The problem with that is that the Wharton's jelly can cause a lot of false positive tests for us in the laboratory. So you need to make sure, as much as possible, that the specimen has not been contaminated with Wharton's jelly. And the nurses are trained to prevent that as much as possible. But of course, things happen. It gets crazy sometimes in the labor and delivery room. Okay, so we need to be aware of the fact that Wharton's jelly can cause significant problems. And generally what it'll do is it'll cause like positive tests across the board, screw us all up. Okay, so this chart here is just a chart of the testing that'll be done in most cases. And we start with, of course, the prenatal testing, which is on your maternal blood. You're going to have your ABO and your D-typing. We knew that. That's done on all pregnant women. And for the most part, if we're in some laboratories, as I said before, AABB used to require that you do week D testing as prenatal testing, but in some laboratories, they have said that, you know what, if we start looking for a week D, we're going to consider a mom D positive. We don't want to do that. A week D mother should be considered D negative because she is capable of producing an anti-D. So some hospitals have said, we're not even going to look for a week D on moms. And the AABB hasn't really fought against it. You know what? That's fine. So if you do a week D, you have to remember, don't let that change your consideration for ROGAM, because week D, moms can produce potentially an anti-D, in particular if they come in contact with full D cells. You're going to do the antibody screen on the mom, and that helps us know if there is already an antibody present and what its titer is. You're going to ID the antibody so that you can characterize it. And then there are a couple of tests that we do to see if there's any mixing of blood. And we have a fetal screen, which is otherwise known as the Rosette test. And you're basically looking under the microscope to see if there's a mixture of D positive and D negative cells. And what you'll see usually is that preliminary association between those cells, and it actually looks like rosettes underneath the microscope. And that's a pretty simple screen that a blood bank might do. Klein-Hauer-Betke test, however, is a stain where we're actually looking for fetal cells. You remember that the fetal cells, the cells that contain fetal hemoglobin, are resistant to acid elution, so those cells will stay pink while the mother cells, the adult cells, will generally turn like ghost cells. So we can easily count, and that allows us to quantify the size of the bleed. Okay, both of these tests have been replaced by automation because we can actually characterize fetal cells. They're slightly different in size, and we can identify the fetal hemoglobin in the cells using automation. So that certainly has helped, but these are still the gold standards, and they're still around in many labs. So those are the things that we did before the birth of the child. So once we have access to the kid's blood, whether it's cord or if you can't get cord, you use regular specimen, you're definitely going to do an ABO and a D phenotyping to make sure that we understand what the difference between the mother and the child is. Now on the child's side, remember, you do have to do a week D. Okay, so on the mom's side, the AABB has said, all right, if you're going to consider a week D as D negative, that's probably theoretically, that's probably the right move. However, on the child's side, you do have to do week D, because if the mom is D negative and the baby is week D, that week D can still generate an anti-D response in the mother. So that you have opposites there. You're also going to perform a DAT on the infant blood, and that's going to help you find any sensitized cells. If the infant has sensitized cells, well, that's a good sign that it's sensitized with antibodies from the mom. So that's performed routinely on all infants born, and it'll help us to identify cases of HDFN, even those which are relatively mild. Okay, now if your DAT is positive, okay, that means the antibodies have been coating the fetal red cells. then you need to remove those antibodies and test them, find out what their characterization is. So basically you're going to elute those, you're going to perform an elution on the infant cells, and which would separate the antibody from the from the infant's red cells. And then you're going to use that elution, you're going to perform, an antibody identification. And remember, you have to consider your ABO cells as well here. So you're going to run it against your A cells and your B cells. Because remember, if you run it just against your panel cells are all O cells. So they don't express A or B. Okay, so you need to find out if you have an A-B discrepancy here between the mother and the fetus as well. And then your panel cells to be able to characterize the specificity of that antibody, which would then allow you to know, how's this HDN going to go. Okay, so those are all things that are going to be done after the baby is born, obviously. So now, in the case of knowing if the mom you have in front of you is sensitized, in particular against D, remember that for a desensitization, we actually do have a treatment. It's the only one we have a treatment for, like a direct treatment for a prevention factor for, and that's Rh immune globulin. RHIG does the same thing as it is an antibody. It's an antibody against D. Only these antibodies are being injected into you. They're not produced by you. If they're not produced by you, that means you don't have a plasma cell making these things. And the goal is to hide that antigen from your immune system, from the mother's immune system, to prevent an immune response from being produced. Okay, so what you're looking at here is antigen neutralization. Okay, so the antibodies are injected into the mother, and you can see there the blue little arrow-shaped things. They're going to basically coat the antigen that's on the infant's red cells. The mom cells don't have D antigen, right? They're D negative. But the infant's red cells do, and so those have to be coated. And they look like little Chinese stars or something. Once they're coated, what that does is it prevents an immune response by the mother, and so no plasma cell production is going to be produced. Okay, so what happens then is that if we can give RHIG to all D negative moms who have not been sensitized, so they've had no previous exposure, they'll receive RhoGAM at 28 weeks gestation just as a precaution. And then another dose when they deliver, assuming nothing goes wrong with the pregnancy, a completely uneventful pregnancy. If, however, there's a bleed, then a dosage has to be determined as far as how much, and we'll go into that on the next slide. Okay. Important to note here, though, if your mom has been previously sensitized, if you already know she creates her own anti-D, it's too late. We can't give her RHIG. It's not going to work. Okay. So we need to, for the non-sensitized mom, we need to be able to give her the doses that are prophylactic. Okay, because if she never encounters a D antigen, then RHIG is not going to do anything to her. However, if there are a few red cells in there from the fetus, the immune globulin will find and bind them. Okay, and so that's why at 28 weeks you get it, and then again at birth when there is another risk for some fetal maternal exchange of blood, then again she gets another dose. However, in the case of a bleed, we have other things that we have to figure out. So again, in the case of a bleed here, we have a little bit more work to do. Okay, so we're trying to detect first of all a fetal maternal hemorrhage. Okay, And the first test we're going to do is called the Rosette test. And that Rosette test, if your hospital still does it, the Rosette test allows us to figure out if there's been, it's a screening test, if there's been any exchange of blood across the placenta. And basically what you do is you take your maternal sample and you incubate it with an anti-D antisera, okay, which is just a reagent that you have in the laboratory. And then you add red cells after that. Okay, the indicator cells are going to form little agglutinates, which they show there in the little cartoon, little rosettes, with any fetal or D positive cells that might be present. Okay. Now you have to know that the mother is definitely D negative. So a Rosette test would only work if you've done weak D testing. If your hospital has dropped the weak D testing from their protocol, you're likely not going to do this Rosette test, okay? Because you do need to know that the weak D is done and that she's definitely D negative. Now, if your Rosette test is negative, then you can, again, just use an RHAG dose. Standard dose is 300 micrograms. And that would suppress the sensitization of 15 milliliters of red cells or 30 milliliters of whole blood, which should be good. That should be good enough protection for the average labor and delivery. So remember, you get a 300 microgram dose at 28 weeks and another one at labor and delivery. Okay. However, if you've got a positive Rosette test, that means that there's been some kind of exchange across the placenta, and so you need to do the next test, which is the Klein-Hauer-Betke test, in order to determine the total amount of that bleed across the placenta. Now, the Klein-Hauer-Betke is just another term, another word for an acid elution test, another type of acid elution test. The cells that contain fetal hemoglobin are resistant to acid treatment. And so this is a smear, it's a stain test. I don't know if you've done it in a blood bank yet, but in the lab. But you make a thin smear of the maternal blood, that's the blood that you have, and you treat it with acid. And you rinse it, and then you counterstain it with a red stain. And you read the cells. You count the number of cells that you see per 2,000 of total cells, because you're going to see both cells with fetal hemoglobin, which will remain nice and red, and you're going to see maternal cells, which will kind of look like ghost cells. And you count all of them, okay? And those ghost cells, once your total cells get up to 2,000, you can figure out your percentage of the fetal hemorrhage. And so you can see there your fetal cells divided by the total number of cells counted, multiplied by the maternal blood volume. So that's based on the total size of your mom. And that'll give you the fetal maternal, the size of the fetal hemorrhage in milliliters that has occurred. Okay. So, for example, if you count 6 cells per fetal cells per 2,000, and you know that the mom contains about 5 liters, which is 500 milliliters of blood, then you have a 15 milliliter fetal whole blood exchange across the placenta. Okay, so that's the gold standard that we've used in the laboratory, and it has of course been replaced by automation. If you perform flow cytometry in your lab and you have a OB department, then you likely have this in your OB department. You can get the exact numbers of fetal cells per milliliter of the mom's blood, and flow cytometry allows you to do it pretty quickly. Okay, so once you have the size of the fetal hemorrhage, then you need to calculate the number of vials. And remember, you're just going to set up a quick ratio. We know that a 300 microgram vial will suppress a 30 milliliter bleed, right? So 1 vial over 30 milliliters. So now change the milliliters, but set up a quick ratio. What's the size of the bleed? Divided by 30 milliliters, and that'll give you the number of vials, right? So it's pretty simple there. The key thing, though, is we're always going to take a little, we always want to be a little bit safe rather than sorry. So if you end up with, of course, if you end up with, first of all, you don't have a whole number, you always round up. Okay, it's not like in math you learned if you have 0.5 or more you round up. No, you always round up. Okay, so even 1 point, actually you do round up if it's over 0.5. So if it's 1.6, for example, vials, you're going to round it up to 2, but then you always add 1 to be safe. So that would be 3 vials in that case. If you have a less than 0.5, so if you have 1.4 vials calculated, then you're going to round down to 1, but you're going to still add a vial. So you're going to make it 2 vials, okay? So you'd round like the normal mathematical situation, and then you add 1 in that case. Okay, and once you've determined that the fetal maternal hemorrhage has occurred, you have to administer that RhoGAM within 72 hours in order for it to be effective. Okay, and that's why when you do have a patient who's had a fall or has had some kind of trauma, they need to be seen right away so that we can determine if there has been a hemorrhage. So these are just some examples. This is the Klein-Hauer-Betke test on the left. You can see the ghost cells that belong to the mother, and then the fetal cells are the ones that remain red. Pretty easy to tell the difference, okay? And you're going to count up to 2,000. It actually doesn't take that long. You're going to count up to 2,000. And that actually can be changed by your hospital. The hospital that I did this at when I was a student, we had to count to 3,000. So we hated these tests. But you can also see flow cytometry allows us to calibrate specifically for fetal cells, and we can calculate the exact population per milliliter of blood. Okay, and you can see you just have to set the gates properly and make sure that the machine is set up to calculate the presence of those fetal cells. And you can see in the final graph, the little yellow circle is showing the actual percentage of fetal cells, and they're falling above the horizontal line. So we get exact numbers when we talk about flow cytometry. So now this is knowing who gets RhoGAM and who doesn't get RhoGAM. Okay. Now, first things first, if the mother's D positive, she doesn't get RhoGAM. Okay, so just because you're pregnant, you don't get RhoGAM, or RHIG is what I should call it. Okay. If the mother is D negative, then yes, she is definitely going to receive, and she should receive RHIG. Remember, if your hospital does weak D testing, even if she's weak D positive, we still count her, we treat her as if she's weak D, as if she's D negative, because of the risk of producing an anti-D. Okay. If, however, she's already produced an anti-D, no, RhoGAM's not going to help. It's not going to help. Okay. So postpartum, when do we, do we administer RhoGAM postpartum? In some cases, yes. Okay. So if the mother's D negative and the cord blood is D positive, that's the case where we're going to add mother. But if you look at the different correlations, the different combinations that you have, in most pregnancies, you're not going to have the issue, okay? Because remember, most mothers are going to be D positive, and so it's not going to come into play. If your mom is D negative and the cord blood is D negative, as long as you've performed a weak D test on that cord, then no, she doesn't need RhoGAM, okay? So this is a nice little chart for you to know who gets it and when.